Hello, everyone, and welcome back to Adventures Through the Mind, a podcast that presents long-form conversations with various guests on topics relevant and related to psychedelic culture, medicine, and research, and always with the underlying question of how can we work with and through and learn from psychedelic experiences to become better people, not just for ourselves, but for all those with whom we are nested in relationship, presently and across time, human and non-human alike. I'm your host, as always, James W. Jesso. Today's interview is going to be with Dr. Mikael Palner, who is an associate professor of clinical research at Southern Denmark University. He specializes in studying the biological correlates of maladaptive neuropsychiatric conditions such as anxiety, obsessive-compulsive disorder, and depression. And in particular to this episode, he has been doing research with various psychedelic compounds at various doses to observe their effects on rats and on the neuronal level of rat behavior. And the study we're going to be discussing predominantly in this interview is his study on administering basically psilocybin microdoses to rats and the effects that had on stress-induced anhedonia, which is a model for depression, as well as compulsive behaviors. The results of the study were very interesting as it kind of indicates a biological mechanism behind the increased stress resiliency and potential for lifestyle change that is reported in the various microdosing community, despite the fact that a bunch of research with humans seems to show that it might just be placebo. His research seems to indicate there is a real biological mechanism behind this. In his exact words, and I quote, "The present results substantiate many anecdotal and self-reported claims from psychedelic microdosing in recent years. These results may indicate a therapeutic potential of repeated low doses of psilocybin in cases where approach and avoidance motivations are in conflict." What that effectively means is that it seems as though there's something about the effects of psilocybin microdosing that creates a increased resiliency to stress, and through that, an increased capacity to move towards changes we'd like to make, behaviors we'd like to make, especially when they're in conflict with behaviors or compulsions that are contrary to the changes we'd like to make in our lives. A full flushed out of what that means and how he came to understand that out of the various research models that he created with these mice and how much psilocybin he was giving them and how that translates to humans. All of that is going to be discussed in this episode. We also discuss how all of this is related to neuroplasticity. And on that point, we also discuss what it is that we know scientifically that psilocybin microdosing does not help you with. And the answer to that is not what I expected, and it's probably not what you expected either, given the culture of microdosing right now and the narratives around it. We also discuss an important caution to keep in mind before starting microdosing in order to avoid this potential harm that we discuss in the episode. And I'm going to read off my notes here, but some other things we talk about is why studies in rats show clear biological effects of microdosing on behavior, but human studies still seem to suggest it is placebo. We discuss a neural level definition of psychedelic microdosing, why microdosing research is being polluted by a lack of specificity, the value of the psychedelic effect, quote, air quotes, of psychedelics in their use as a clinical medicine, and why rats need higher doses of psychedelics to get high. If you're curious about a particular section of the episode, timestamps are always available if you're watching this on YouTube or on various podcasting streaming platforms. So take a look in the description, jump over to the bits that you like. And other than that, without any further ado, this is my interview with Dr. Mikael Palner on Adventures to the Mind, episode 194. Enjoy. Mikael Palner, welcome to Adventures to the Mind.
Thank you. Thank you for having me.
So I recently read a study you were a part of with respect to the effects of, you say like, I think long-term low-dose psilocybin administration in rats, which, I mean, in common parlance, is maybe something like microdosing, and its effect on stress. So, I mean, unless I got something incorrect there that you want to, expand upon or correct, I'd be interested to start the interview today with I guess like a general outline of what microdosing is, and why you chose to do this research with rats instead of humans.
Yeah, it was perfectly explained on the title and stuff. So we actually chose deliberately to call it low doses instead of microdosing, because microdosing kind of implies, in pharmacology at least, that you are giving a really low dose of a drug that doesn't have any effect. That's how you were going. If you go back and look at microdosing papers in toxicology, you would give a very low dose of a drug and you would see what is this drug doing pharmacokinetically and stuff like that. So because we have effects, we're not calling it a microdose. We're calling it a low dose, and we're doing a chronic, subchronic psilocybin treatment. So if I turn back time a little bit, when microdosing was kind of having the boom, I was a postdoc at Stanford University and living right in the middle of the Silicon Valley, where a lot of people were talking about microdosing. And doing my PhD, I was actually involved in developing a radioactive tracer that can be used for something called positron emission tomography, where you can image the brain and receptors in the brain. And we developed a tracer that could image the serotonin 5-HT2A receptor, which is the receptor that most of the psychedelic drugs actually work on. So when I was reading up on microdosing, I was thinking, hey, I have the tools to actually study this in a really good way, because all of the microdosing stories that came out at that time were anecdotally. There was only reports of what's going on, what are people writing on Reddit, how are they feeling, but there was no real studies at that time. And we had this way of establishing this in rats because we could measure how much psilocybin was binding to the serotonin receptor. Because obviously the problem doing a study in rats is that you can't ask them if they're having a psychedelic trip. So there's behavioral ways to study it, but I think the more correct way would be to analyze the binding directly to the receptor that is involved in the psychedelic episodes. So since we had a friend of mine and a colleague of mine, Martin Madsen, had just done a study in humans with this radio tracer and looked at the correlation between psychedelic intensity and occupancy at the serotonin receptor. And they had established a dose of 25 milligrams of psilocybin was a really high dose, and you had a high intensity. But what was also obvious from the study was that as you go lower in occupancy and lower in dose, you also had lower intensity. And from the curve of binding to this receptor, we could actually figure out a measurable way to figure out how much is a microdose. And it seems like if people had below 20% binding to the receptor in the brain, they didn't really have any psychedelic effects. So they had they could feel the drug, but they didn't have any psychedelic effects. And the notion about microdosing at the time was that it was a sub-perceptual dose, maybe about 1/10 of a big dose. And as it turned out from Martin's study, 1/10 of a high dose was about right for where they could not feel the drug anymore. And it was about 20% occupancy of the serotonin receptor. So when he had done this study and I knew how this whole system was working and I was a colleague with Martin, I thought, okay, maybe we should actually do it in rats and see if there's something to it. Because in rats, we can do a study. We know they have not tried psychedelic mushrooms before, so they're not biased in any way. We can also blind the participants. We are sure that the rats that doesn't receive psilocybin are not sad about not receiving psilocybin or not don't have a bias towards microdosing producing something good for them. So that's why we chose to actually establish this regimen in rats.
So when you say occupancy, 20% occupancy, does that mean that, okay, so theoretically 100% occupancy would mean that 100% of the 5-HT2A receptors in the brain have psilocin binding to them? Or does it mean that a particular receptor site has multiple binding opportunities? Maybe you can explain that a little bit more as to what this occupancy is and how you determine percentage.
Yes. So the radioactive tracer and a drug that we have that we inject in the body and we can see in the brain when we come into a scanner will bind a small part of the receptors. But we can estimate how many receptors there are from this small part of binding. And then when we give psilocybin, these two drugs will compete for the same binding site. So that will be like a key into the lock of the receptor. There can only be one key at a time in the lock. And psilocybin will then kick off the other one, the radioactive drug. So if you have 100% occupancy, it does translate into all of your 5 serotonin receptors being bound by psilocybin. That is probably never going to be the case. We tried to estimate how much was the maximum occupancy we could get at, and in rodents and rats, we get about 60 to 70% of the receptors when we give them a really high dose. So with this, we can then calculate that if about 20% of the receptors are occupied by the drug, you don't really have any psychedelic effects. And we call that a low dose and not a microdose.
Okay, so something I found interesting. So you came to the conclusion, or you determined that in order to get this 20% occupancy in rats, they needed about 0.05 milligrams per kilogram of psilocybin, which if I translate that to humans based on those same numbers, then for a 70 kilogram person, total that would be about 3.5 milligrams of psilocybin. Average your standard.
Go ahead. That's actually almost on point what Martin reported in their study. They found about 3 milligrams was about 20% occupancy.
Okay, so what was interesting is with mushrooms. Okay, so I'm kind of combining two questions here, so we'll see how this goes. With, say, the standard dosage of psilocybin in a dried, middle of the road psilocybe cubensis, of course, potency can vary to strain and then species of psilocybe, but just middle of the road cubensis, that 3.5 milligrams would amount to about 0.5 grams of mushrooms, which certainly, again, a lot of variation in mushrooms, variation in people, and sort of subjective tolerance, but also maybe genetic variations in how they metabolize this compound. But what was interesting to me is the idea of hearing that 0.5 grams of mushrooms would equate to what, at least when I first read it, I just assumed when you said low dose, you meant microdose. This is perhaps my error. 0.5 grams is pretty high. I tried being maybe I'll try 0.5 grams as a microdose. And it was that stereotypical, this is not a microdose moment. So I guess the question is twofold. One, why this maybe discrepancy, why it is.
Yes.
And then the other one is what's the difference then between the rats and the humans, such that it would theoretically need more for them to get this 20% occupancy, if the rats are generally used as a sort of good model for seeing how a human brain might theoretically respond to certain drugs.
Yeah. So there's several parts to that question, and I think the first one is, so you sent me your calculations beforehand. So I saw that you estimated 0.65% psilocybin in the cubensis. We actually tried and measured it in some cubensis and got 3.5%. So obviously there's a huge difference in how how strong are mushrooms. So it really depends on where you grow them, how you grow them, and whatever. So I personally wouldn't translate it into mushrooms in that way. That would be really difficult. It's probably better to try the mushrooms you have and dial it down. Also in science, we rarely use mushroom extracts because it's so variable. So always in science, they use pure psilocybin, and 25 milligrams of psilocybin is one of the most used doses of high dose psilocybin in clinical studies. And if you then look at it, 3 milligrams of psilocybin is about 10% of that. So I would be careful to translate it into mushrooms, but I think the 3 milligrams of psilocybin is pretty close to a micro, maybe a mini dose.
And so perhaps one compounding factor, and part of the interruption in your train of thought there is, from what I understand from some of the other research I've read, that there's some reports that eating the mushroom itself compared to psilocybin, theoretically, this amount of mushrooms has 25 milligrams of psilocybin.
Mm-hmm.
Then this capsule has 25 milligrams of psilocybin. That people generally report subjectively stronger effects from the mushrooms, and this may have to do with entourage effect of various other, I believe the term is psiloids, that might be present in the mushroom.
Yeah, there's more than 40 alkaloids in mushrooms, and we don't know what half of them are doing.
Mm-hmm.
But what we do know is one of them is a monoamine oxidase inhibitor. So you will have a stronger effect of the mushrooms simply because it's inhibiting the metabolism of psilocin. And that's to the next way when you have to translate something from a rodent into a human. It's not a one-to-one translation either, because rats have they have a very efficient metabolism, so they metabolize most drugs much faster than humans. So the action of psilocybin is also slightly shorter in rats than it is in humans. And the second one is that rats have a very efficient blood-brain barrier. So a lot of drugs that you give to rats simply doesn't come into the brain in a very large amount. And therefore, you may need to give much more to a rat than to a human in comparison. And a good example is actually LSD. So when we do the exact same study with LSD, we would need to get a full dose in a rat, we would give them 0.16 milligrams of LSD per kilo.
Per kilo, yeah.
Yeah. So, and a rat is about 300 grams. So, 60 milligrams of LSD to a rat.
60 milligrams. That's not to be confused with micrograms, because like normally a human would be like about 100 micrograms, and you're properly there.
Mm-hmm.
Yeah, which is 1,000th of a gram rather than a milligram.
Yes.
Right. Yeah. Or 1/10,000.
Not 60 milligrams. Sorry, 0.06 milligram. So
okay.
So that would be
60 micrograms.
Yes.
Right. Which would be, for a human to experience something at all is usually somewhere around 10, 15, 25. So that is significantly higher for the
we give it to a rat. We give 60 micrograms to a rat, right? So, and then if you have to scale it up by weight, you would give a lot more to a human, right?
Mm-hmm. Okay.
But it's also interesting that we don't really see any effect of weight in humans. So that it doesn't really matter that much how much you weigh. You give this, it's more or less the same amount you need.
Okay, so let's so we now have a sense of like, okay, this using this PET indicating drug that you've determined, all right, about 20% occupancy. This is the dosage we need to give the rats in order to get the 20% occupancy. And then you use like I think the word is like models. So you run a couple of models for different conditions to put these rats in, and then test the results compared to not receiving the low dose and receiving the low dose. Can you give us a rundown of like each of the various models that you use? And not so much Yeah, maybe the conclusions as well. So start with the models that you use, and then why you use that particular model, like what its translation is, and then the results you came to.
Yeah. So obviously we can't see a lot of the psychiatric or well-being. We can't see mood in a rat, for example. We can't see other things. So we have to try and figure out a behavior in a rat that we then say, okay, this is similar to what we would see in a human that does something. And for doing this, one of the most used behavioral essays in rats is an open field test. So if you put a rat down in a large square box, you know that rats will tend to run in the corners. If you have ever seen them, you always have them running next to houses and stuff like that. So they prefer to be next to corners. And you can then measure how much they venture into the center field of this open field. And the more they venture into the center, the less anxious we say they are. So it's not to say that they are anxious or not anxious, but we tend to say that they are less anxious if they venture into the middle of the field. So the open field can also be used to track locomotion. If you give a rat amphetamine, it will run faster and more in this open field, and we can track that over time. So it's a really good test to see, is there any effect on locomotion? Do they run more? And is it simply because they run more that they are more in the center? And then you can do other behaviors like they're standing up and rearing and looking around. And the more they stand up, the more explorative they also are. And at the last one is then grooming, because the rats are spontaneously just trying to fix their hair. So they will groom if they are in a place where they feel comfortable. They will just start grooming. And they do this a lot. So you can then track the amount of time or the amount of bouts it's called. So every time they groom one time, it's called one bout, and you can then count either how many times it grooms or how long time it grooms, and you can then have this as a measure of how much spontaneous grooming activity they're doing. And I try to compare this grooming activity with us humans maybe checking our phones. If we are not sitting and doing anything, everybody will take up their phone and see if there's any new notifications. And I kind of see it the same way. They will fix their hair or try and make their fur look nice and clean before they go on with another job of that day. So it's kind of like a small habit or compulsive behavior, if you like that. So that was one behavioral test that we'd done, the open field test. A second behavioral test was actually how much does these animals like to drink sugar water. So if you teach them to drink sugar water, they will prefer to drink that because it tastes sweet. And they will probably drink around 60 to 70% of all their fluid will be from sugar water. But if you stress an animal, and then it tends to lower the amount of sugar water it will drink. And we look at this behavior as a kind of an anhedonic behavior, that you are not interested in pursuing pleasurable experiences. So if you are depressed, you may not want to go out and have a pleasurable experience, which is called anhedonia. So we kind of try to compare this not drinking sugar water with this anhedonic experience. So those are the two main tasks that we used in the. And then other than that, the animals or the rats are completely normal rats. So we don't have a model of a disease in this case. We have completely normal and healthy rats.
And so you have these like two primary like things that you're observing. So you have the open field, and then you have this grooming thing. These are the things you're observing, the behaviors. And so you're then stressing the rats in particular ways. Is that correct? And then testing how the rat behaves without the stress, without the psilocybin, with the stress, without the psilocybin, with the stress, with the psilocybin. Is that correct?
Yeah, so we didn't actually set out to stress the animals per se. We were trying to figure out how to give psilocybin to the animals over a 3-week period every second day. And the only way to give it consistently is actually giving them small injections of psilocybin, and you can do that just below the skin. Then you can give them a small injection. That is probably the least stressful way to give them a drug over a long time. But at the same time, it is a stressful thing to get an injection of either saline or saline with psilocybin every second day over 3 weeks. So that turned out to actually be a stressful event that we could then follow in this sucrose preference test that we had established, where they were drinking either sucrose, sugar water, or normal water.
And so, what did you find with the rats that were given the psilocybin compared to the not? Now, you have the open field test. You have the anhedonia test, and I believe there was also a behavior that you observed that may translate out to what we in humans call obsessive-compulsive disorder, and I believe that's grooming, correct?
That's the grooming, yeah, the compulsive, spontaneous and compulsive grooming. Yeah.
So let's divide those up separately, and then what did you notice in the psilocybin rats versus the non-psilocybin rats?
Yes, so doing the study, we were doing the sucrose preference test because we were trying to do many measurements of this, and we noticed that the animals that were injected with saline became stressed during the period because they were being taken up or given an injection every second day, and that makes sense that they get stressed from this. So they tend to drink less sugar water over time, and then more and more over time, you could see that this dropped. And then once we stopped injecting them with saline, they returned back to normal, and then they started to drink this sugar water. But the animals that we gave psilocybin in the saline water didn't have this anhedonic response to the stressor. So we could see that they preferred equal amount of sugar water all throughout the test and were not stressed in the same way as the animals, or not anhedonic in the same way as the animals that received the normal saline injections. So that was the sucrose preference test. It seemed like they were less stressed.
And so before you move on to the next one, like an interpretation of that would be that the every other day psilocybin administration at this low dose, what would be a microdose, right? Seem to protect from stress-induced anhedonia?
Yeah, or just protect from maybe stressors of everyday life for a rat. We gotta remember it's rats, and
of course,
it doesn't mean that it will work the same in humans, but it seems like it protected them. Maybe they were more resilient to stressors. And it's important here to note that the sucrose preference tests were done on days before they received their psilocybin. So it was not doing the psilocybin that was working, it was on the other day, and then or 2 days after actually the psilocybin dosing, and then they were dosed right after we had this test. So the drug was out of the system and not working at the time that we were trying to measure this. Then after this whole microdosing regime that we have set up in animals, or low dose regime, then we waited a couple of days, and then we tested them in the open field, and we measured how much they ventured around, and there was no effect on locomotion. They had the same amount of speed, and they traveled the same amount, both saline injected rats and psilocybin injected rats. And there was no effect on anxiety directly. So they didn't venture more into the center of the field, and they stayed the same amount in the corners.
But when this is on the same days that they were given psilocybin, or was this observed just before the dose on the second day?
This is so the open field test was done 2 days after the last psilocybin dose. So they had received psilocybin for 3 weeks every second day. Then we stopped, and then we waited 2 days, and then we did the behavioral test. So also the psilocybin was out of the system.
Right.
And then we measured then also how much grooming they were performing in this open field. And we could see that they were grooming the same amount of time, but having less grooming bouts. So they initiated their grooming sequence less times. And that is like a compulsive event for them. They want to groom and they do groom, but they did that less. And you can maybe it's a stretch to compare it to obsessive-compulsive disorder, but it is a compulsive action that they are doing, and it is a lowering of a rat's compulsion to groom.
And this observation of grooming behaviors, that was also after the 3 weeks and 2 days?
This is in the open field arena where they are also running around. So you can do all those measurements at the same time.
And did you test them at all while they were still receiving the psilocybin in the open field and in the grooming behaviors and such?
Not in this experiment. We haven't tested them doing the. They were left in their home cage, in their home environment, hopefully feeling good and at ease. So no, we didn't test them while they were on the drug. In this case.
So it was only the sugar test that you did while they were being administered the psilocybin.
Yes, but also not on the day, not at the same time.
Yeah.
So the drug was out of the system when we tested them.
So what did you come to out of these various models, these various tests, the results that you got? Like, what kind of conclusions were you able to, at least tentatively draw with respect to the effects of providing these chronic low doses of psilocybin to rats?
It's actually interesting because one of the first clinical studies that were done in, maybe we'll call it the new era of psychedelic research, right? It was back in 2008 by a guy called Moreno, and they actually did a psilocybin clinical trial in a small subset of humans with obsessive-compulsive disorder. And they gave them also very low doses, and they saw an immediate effect on the compulsive actions that they had. So what we are thinking that these microdoses could do is that they could increase the resilience to stress in animals and lower the urge to do compulsions.
This kind of it echoes. There's a comedian performer named Adam Strauss. I've had him on the show, and he is somebody who has diagnosed OCD and explicitly has sort of part of one of his comedy routines, but a part of his sort of advocacy for psychedelics has been to speak to how his experience working with psilocybin seems to have sort of played a positive contribution in his life with respect to managing his OCD.
I tried to get his watch his show so many times, but it seems impossible from Denmark to get to see it. But yes, I read about him, and we also have anecdotal case reports here from Denmark where people have used small doses of psilocybin to help with their obsessive compulsive disorder. And there's also published cases of this. In single people, like case studies where they also have reported using small low doses for obsessive compulsive disorder. So there's a little bit of evidence coming up, but we don't have any clinical trial that supports this yet. It could be placebo, it could be whatever, but there's a faint grasp of hope that it may work.
So you might have just explained this. So I might be asking you to repeat yourself based on a different angle of approach. But in your paper, you write the present results substantiate many anecdotal and self-reported claims from psychedelic microdosing in recent years. These results may indicate a therapeutic potential of repeated low doses of psilocybin in cases where approach and avoidance motivations are in conflict. Can you explain what approach and avoidance motivations are and what they look like when they're in conflict?
That is also based on the findings that we found in the brain of these animals. So maybe if we just go back to the results where we have actually, one thing about rats that you can't do in humans is that you can take out the brain and we can analyze it afterwards, and we can see is there something going on in the brain of these rats. And we could actually measure in a region of the brain called the thalamus, we could measure increased synaptic plasticity, and we had more axonal terminals in this region. And this region is also involved in what we call approach and avoidance behavior.
Can we just take a pause there for a second?
Yes.
You said axonal terminals. Can you just explain that a little bit in maybe more like layman's terms? Do you mean as in like just like more axons, like as in like more synaptic density or something?
Yes. So all the brain is full of neurons that have that are connected to each other and they have one connection going out that is called an axon. So we have one connection that is going out that's called an axon, and if you have more in the end of this axon, there's actually, it spreads out and it gets into these what is called synaptic connections. And the neuron is then connected to another neuron by touching these synaptic connection with each other. And when we see more of these, we see more of these synaptic connections, which is also called synaptic plasticity. If you follow the psychedelic literature, you will see that there is a talk about increasing synaptic plasticity. And that is what we see in the thalamus of these rats.
Okay. And you were about to explain how this synaptic plasticity and this region of the brain are related to this approach and avoidance motivations being in conflict, and then explain a little bit more about what that means.
Yeah, so approach and avoidance really means that if you are a smoker or drinker, for example, you will want to have your cigarette or your drink, but you also know that it's bad for you. So you have this pull towards something that you want, but also a push away. So this is the approach, and then you have the avoidance is a push away that I know it's bad for me. I shouldn't do it, but you still want it. Or the cake at 4:00 in the office, right? You really want it, but you also know maybe you shouldn't eat it. So that is an approach and avoidance behavior. And in compulsive disorder, or obsessive-compulsive disorder, most of the people that have obsessive-compulsive disorder knows that it's not good to act on my obsessions because with this compulsion I have, because it's going to be a repetitive pattern. And even though I get relief from doing the repetitive or compulsive actions, I get relief on the anxiety. It's also a reinforcement. So if I do it and I get relief, I will want to do it again and get relief. And that is how we believe that these compulsions are actually starting. So that is also an approach and avoidance conflict. Yeah, that I want to do my repetitions, but I also know that it's bad for my continuing OCD to do them.
And now, does that have to be an OCD, or do we see these same behaviors in people that, I mean, anyone can have a compulsion? You mentioned picking up the phone. For most of us, picking up the phone is a compulsion, right? But we don't have OCD.
Yes. No, so the approach avoidance behavior is seen in many cases, like in smokers or binge eaters or just regular people who have some kind of compulsion that you have an urge to do, and without having obsessive compulsive disorder, of course. There's many cases.
And so, in this area of the brain, you said the thalamus?
It's called the paraventricular thalamic nucleus, but it's part of what is called the thalamus.
Yes, you have to pardon my lack of specificity, lack of neuroscience background. Now, and so it's associated with this sort of area of the brain. And then, you did some tests or observations of the rats that you gave psilocybin? Like, what was the relationship to speaking about this area of the brain and your research specifically with the rats? Like, did you study psilocybin's effect on this area of the brain to draw conclusions with behavior?
Yeah, no, we didn't look at the whole brain. That's the first thing to say. So there could be many areas where this is happening, but the reason we looked at the paraventricular thalamic nucleus is that it's very rich in another receptor type that's called the serotonin 7 receptor. And there's 14 different receptors of the serotonin class, and you have the 5-HT or the serotonin 2 receptor, which is primarily responsible for the psychedelic actions, but then you also have the serotonin 1 and 7 receptors that look alike. And we looked at the serotonin 2A and 2C receptor, they're called, and then we looked at the serotonin 1A receptor and the serotonin 7 receptors. And when we looked in the areas of the other receptors, we didn't really see anything. But when we looked in the region where we have a lot of serotonin 7 receptors, we saw this upregulated synaptic plasticity, so more synapses in this region.
And so so you're like from that drawing the conclusion of like, oh, so psilocybin we might be seeing a biological basis for these behaviors with respect to approach and avoidance motivations being in conflict.
Yes, that is the conclusion. I think so, especially because we have a very low dose of a drug, we have a non-psychedelic dose of a drug of psilocybin, and we are seeing changes in the behaviors that match the changes we see in the brain. At least on a regional level, we know that this brain area is involved in these compulsive actions and approach avoidance actions. So we're trying to link the two, but we need more studies to actually conclude that they are connected and that this is what we see. So we are working on more studies at the moment to try and figure this out. What is the effect on compulsive actions and approach avoidance?
Now, at this point, in maybe the overall research, but in particular in your research, like, are we at a point where the data that we have is suggesting that that what's being observed here can be translated out into humans with respect to like identifying a reliable biologically driven effect from microdosing to, modulating or supporting difference in human experience and behavior?
I think that's still an open question, but more and more research is coming out, especially in animal models, that we can see that sub-psychedelic doses do have an effect. And there's been studies with fear conditioning where you look at PTSD-like symptoms. There's been studies like in compulsive actions and in animals with depression as well. And we do see effects. How it translates into humans, and if it can translate into humans at all, is still an open question. But at least in the animal studies, we are free from all that bias that is usually in the human studies. Because it's going to be really difficult in human studies because of biases towards I'm getting a drug and maybe this works and I believe it works. So the placebo effect is also really, really strong in humans. And if we're going to see an effect that's actually larger than the placebo effect, is also that I don't know that yet, but I think it's worth pursuing and trying to see if there's an effect of microdoses in humans. Because if there is an effect of these drugs that are not psychedelic driven, then we know that it's not the psychedelic effect per se that is part of relieving people of, for example, depression or obsessive-compulsive disorder. But it may be something pharmacological, and then we can go in and redesign the drugs, right? So if from my side, I see the psychedelic effect as a side effect because a lot of people, and particularly people with anxiety or obsessive-compulsive disorder, doesn't really want to get into a psychedelic experience. Maybe they're afraid enough stuff is going on in their head to do this. So it's beneficial to have other drugs that can help these people, especially drugs that don't have a psychedelic effect, and in that way can help people who are feeling a lot worse than just regular human beings.
I mean, I have no opposition, and in fact, I have a supportive, like, go get them, let's do it, for finding, what are they called, like third gen psychedelics or something like psychedelic drugs that don't produce psychedelic
Yeah,
effects.
non-psychedelic.
Right. So there's a lot of,
yeah.
I see a lot of utility for that. There's another aspect for me though, that my heart hurts a little bit when I hear the psychedelic effects of something like mushrooms, or, to be described as a side effect, like an adverse effect, in contrast to the sort of like the key point and purpose of consuming this substance or molecule, especially since, and
but it depends on what your key point and purpose for consuming the drug is, right? So if your key point and purpose is to have the psychedelic experience, then of course it's not a side effect, then it's the effect. But then you will have a side effect that's called increased blood pressure and increased heart rate, because you will also get that, and that is definitely a side effect of the drugs as well.
Right.
So,
I will also get that riding a bike vigorously.
yes.
I would get that. I've heard this example of like if you took somebody's blood measures and like all of their vitals in the middle of a really intense workout, and all you knew were those measures, you'd be like, oh my God, this person's dying. But actually, this is a part of the sort of like stresses and the challenges that over time create resilience and health and well-being, when they're contained within a certain sort of like boundary that prevents injury psychologically, physically. And to me, I think, I can appreciate, and I see there's a lot of value in developing psychedelic based drugs that don't have psychedelic effects, because they could have a lot of utility. And simultaneously, I think one could go in not for the psychedelic effects, but for the very same sort of like resolutions on the other side that somebody else is going in to take the microdose for and not have effects. And the psychedelic effects, the experiential aspects of that playing an important sort of core aspect of those resolutions. And in that way, I think generally it pushes my bias edge, the sort of like the try and eliminate the psychedelic aspect of the drug, because I think it goes back to a kind of bias in certain areas of science and society, where anything that alters your mind outside of a particular window of allowance represents like a problem, rather than represents an opportunity for a different way of being or experiencing the world.
I think it may be because you see the word side effect in a negative view. I don't see it as in a negative view per se. It's just not the effect that we intend to get, right? So if we intend to get an effect on compulsive actions, then anything other than that would probably be a side effect. So I don't think it's bad. And when we're trying to develop new drugs without psychedelic effects, we're also not trying to remove drugs that have psychedelic effects. I think there's pros and cons for both. And I also think, so I've been thinking about this a lot because it's a question that comes up a lot as well. And there's definitely some aspects of the psychedelic experience that is really useful in some disorders of the mind or some places. And there's definitely other places where it may not have a big impact. So in one end of the scale, you would have something like headache or Horton's headache, where we know that the vasoconstriction is probably what is doing the thing, and that is probably has the healing effect of Horton's headache is probably nothing to do with the psychedelic experience. Where on the other end, you would have something like end-of-life anxiety, where you have this existential crisis and you're going to die. And then I think having the psychedelic experience is probably the most meaningful thing you can do at that point in life.
Right. I mean, so, if I'm on my deathbed and someone says, okay, well, we could give you this drug, but the side effect is if you have a mystical encounter of like, becoming and merging with God and knowing that your life continues even as your life ends. Or I could give you this other drug that does the same thing pharmacologically. You just won't have any experience at all, and you'll just feel nice. You'll feel less compulsive. I mean, like as much as it would terrify me, and even the idea of being on my deathbed, of course, there's going to be a lot of fear and anxiety, associated to that for most people. I'll probably still choose the one that puts me at my utmost challenges and meets me with God than the one that might relieve it just a little bit. Yeah.
But maybe that's because you are at ease with God as you are now, or at ease with the whole thing. I mean, I could imagine some people that don't want to go there
Yeah.
before they die. Maybe they want to die in a different way. So,
Yeah,
but
and
that's a big
fair
question.
enough. Fair enough, right? And we're like, wait, we're not going to come to the absolute conclusions on the relevance of God in this conversation.
No,
Why are we even talking
no.
after all? Okay. So if I like turn back the wheel of time, and I try to stay as up to date, as reasonably possible on psychedelic research within the sort of frame of the bandwidth of capacity I have. But even I think if I had, my full-time job was watching all the research coming out at all times, I would still not be able to keep up. Like there's just so much coming out, right?
That is my job, and I can't keep up.
Right. So with that said, I acknowledge my own ignorance with respect to what's happening right now with microdosing research in particular. But if I go back, one of the sort of first big studies that came out was, I don't remember the exact sort of structure of it, but it was basically anecdotal reporting. And the overall conclusion was them coming to like, well, it seems like it is, no different than placebo. So perhaps we have new research that you know of that you could say, no, evidence is suggesting it's not placebo. Or maybe you have some comments on why we might be able to see these pharmacological, biological results in animals, but we're still just getting placebo likely in human trials.
I think there's two reasons why, and the study you had was in probably the one in people who have signed up and had their own dose, and then they took their dose and they then reported how they were feeling afterwards, and they didn't see any change in how they were feeling compared to the people who are doing the placebo study. But I think there's two things to this. This is in normal people, or what we would call controlled people, and I don't think, maybe if you are at the best of your life and you are already relaxed, I don't think there will be any benefit to it. Doesn't seem like there would be a benefit to it. It's more if you have, from our animal studies, it seemed like if you are challenged, if you are stressed, if you have some kind of psychiatric disorder, then maybe there's a better way to get better. Because if we are already at 90% of our capacity, maybe there's not a lot of room to get better. But if you are maybe at 50% of your capacity because you have some kind of disorder or challenges in your life, then there's much more room to increase in order to see an effect. So that might be one thing. Maybe we have to look in disease models in animals or in people with certain kinds of challenges and disorders or diseases. And the other thing is also the dose that people have been reporting in some of these studies varies a lot. So if you are telling people to go home and use their own mushrooms and grow them and take them and figure out what dose to do, this will vary a lot. So that will create a lot of variation in the group that are microdosing, from people who can't feel it at all to people who are taking 0.5 milligrams and definitely can feel it.
Yeah.
So that also creates a lot of variability and makes it really difficult to distinguish between placebo effects and normal effects. Generally, all the studies that I've seen, people report that if they get a microdose, they know they're getting it. So most people will be able to tell the difference between not receiving psilocybin in a low dose and receiving psilocybin in a low dose. Maybe it's close to having a beer Friday afternoon or coffee Monday morning or something like that. But you will be able to tell the difference if you had it or not.
Well, I suppose if somebody is coffee naive, they're absolutely noticing a coffee. Many of us forget how strong of a drug coffee is if we're having it all day. But something that I think is interesting there is, there's this sort of the general phrase is, a microdose is like just shy of whatever dose will have you feel an effect. So a microdose is something where you don't feel the effects. And I always, I've also propagated this premise while simultaneously being like, it seems a bit weird because if you're not getting any effect at all, you're not experiencing any effect, then why are you taking it? What's the actual point here?
Yes.
So what I hear you saying is that there's clearly some kind of effect. People are clearly noticing, like, hey, something's different. And if something
at
is
least
different,
that's what they see in all the studies that have been carried out, where they give people a microdose. Then they can definitely feel it. So if you can't feel it, you're probably not taking enough.
I'd like to take a quick little break from the interview to thank my patrons on Patreon who make this podcast possible. Without your voluntary contribution to the resources necessary to produce the show, both financial and time, which ultimately costs money, it would not be able to exist. I would not be able to put in the hours and the financial resources to the technology and hard and soft that make this podcast possible. And more than that, I wouldn't be able to live working my full-time job as being this thing I so deeply care about, unbeholden to outside interests, just following my curiosity in relationship with you and your curiosity on things that we both care about, things that we both feel matter. And that is incredibly special to me, and you make that possible, and I really appreciate it. Thank you. If you listening are not yet a patron of the show and you are finding value in what you're receiving here, I invite you to reciprocate that value by becoming a patron on Patreon. All I'm asking for is as little as a cup of coffee once a month, which really does go a long way, and it allows me to literally and figuratively keep the lights on here in my work as a podcaster and a researcher on psychedelics. So please do that. Patreon.com/James W. Jesso to become a patron. Really appreciate that. If you're doing it on an Apple device, an iOS device, please don't go through the App Store, because Apple, they're going to charge you an extra 30%, or they're going to charge me 30%, which they only implemented last year, and I think is hot garbage. If you just sign in through the web browser, sign up there, then you can access it through your app. No worries, and then you don't have to pay that 30%, or I don't have to pay that 30%. And Apple they don't need your 30%. They didn't deserve 30% of your pledge, period. So up to you though, whatever's most convenient. If you just want to sort of drop a little tip for an individual episode, there will be donation links in the description of this episode, wherever you're checking out. And either way, I do appreciate it. And I appreciate your time and attention, whether or not you give financially. You're giving your time and attention to that, and I appreciate it. And those who can already are contributing financially, so we all get a podcast. I get to make one, and you get to enjoy one. So back to enjoying the episode, at least. Fingers crossed. I hope you're enjoying it. So, with the microdosing research that we do have, the complexity of placebo and not placebo, and like the difficulties in blinding and the sort of variability of results based on like who's being given it at what dose and how are they reporting and how are they being recruited and so on and so forth. What's clear is that, at least generally, at least in the corner of the internet that I'm in, microdosing is like all the rage, right? And like any novel health intervention in a health, a profit-based health industry, which supplements are in, microdosing in this respect we'll consider a supplement, because we're not talking about something prescribed by your doctor here. We're talking about something that you're either formulating at home, or you're literally buying a microdose product off the internet. So we're in this context where microdosing is popular, it's potentially profitable, and, judgments aside, I'm not making any claims one way or another. What is clear is that people tend to speak very highly on the benefits of things. And at times, those benefits have little to no basis in any research to support them. And as a consumer of these products, or a consumer of the content that is attempting to sell these products, literally sell us these products, or figuratively sell us the concept, we aren't always doing our due diligence, right? So this is the landscape of microdosing presently.
Yes.
Right?
Yes, I agree completely.
Right. So based on the research that what can we, obviously we can't say certainly, and I'm not asking you to say certainly, but what can we reasonably guess is likely to be some potential benefits of microdosing for whom, and what can we reasonably say likely isn't going to be a benefit that we get from microdosing? And I'll just say psilocybin in particular, not to then further convolute the thing by any number of psychedelics that could be included, right?
Your last comment there, let's get back to that a little bit later.
Okay.
Because that's definitely polluting the field. But with regards to psilocybin, I want to start out with what can we say is not going to be good for a person, because there's actually been a lot of studies with low doses of psychedelics and the acute effects of low doses of psychedelics, not in a microdosing regime or like in a way, but they've just seen, are people better when, are they more creative, are they more do they complete tasks better when they're on a microdose? And all the studies that I read, and there's at least a handful of studies, and all seem to agree that people who are taking a microdose get worse at doing stuff. They don't get more creative, at least not doing the drug, and they are certainly not better at solving tasks like we have behavioral tasks where we can measure people's cognitive flexibility or the way we process problems and solve problems. And it doesn't seem like we are getting better, but maybe that's not the point. Maybe the point is to take off the stress, and you don't necessarily want to be better, but if you take off the stress, maybe you're feeling more calm about it, and in that way you're getting better. But I don't think we can say anything positive about microdosing at the moment. We can't say that there is anything that makes us better, but we can certainly say that while the microdose is working, you are performing worse.
And when you say performing and getting better, you're meaning specifically with respect to productivity and creativity, like
cognitive tasks in general. That could be everything from solving a Sudoku to doing a math problem, or doing house chores, the challenging things where you do, or work stuff where you have to switch between tasks all the time. So those, it seems like it's worsening our ability to switch between tasks and solve problems. Creativity, it also seems to have no effect on creativity, but it's more... it's very difficult to measure creativity.
I can see this very subjective if somebody feels more creative or not. Yeah.
Yes. And to measure that in a scientific way is really, really difficult. So I wouldn't be a judge on that.
Okay. So then what do we have evidence to sort of reasonably say it, can help with? And when I say can, I'm not saying definitively, like as in based on the research we have, it's likely that sometime in the future we will show relatively conclusive evidence that it is likely to support fill in the blank.
Yeah, I'm gonna. I don't know if I'm going to say anything. I'm skeptical about it, that it's going to fill in something. But the areas where we can see something in rodents is with anxiety and compulsive actions, and maybe just take the edge off things, so make you relax a bit. That's probably where it will be maybe more social connected as well. But again, there's no evidence of it, and I wouldn't recommend it for anybody who feels perfectly healthy and going about and having a normal life. I would not recommend it. Because think about it. If we for a second say that microdosing increases synaptic plasticity, and we take that for granted, and it does, then you don't want to have synaptic plasticity all the time, right? You don't want to have this increased flexibility in your brain, because that is what happens to our brain when we go through development. We have a highly flexible phase in the first year of our life, and during our teens, we also have brains that are highly flexible, and you don't want to have that all the time. Figure out if you are like in a car accident or in a violent relationship, and you go through and have these increased cognitive flexibility. Maybe the trauma you're actually experiencing by accident in those phases will actually be stuck in a more rigorous way than it would have if you were not microdosing.
I mean, that's understandable. Yeah, because it's like if neuroplasticity represents learning at the neural level, then neuroplasticity for neuroplasticity's sake doesn't really amount to much. And if you're not careful, it could actually amount to sort of like a detriment in some way. Like there has to be some sort of purpose. Like it needs to be serving some sort of purpose or goal that's, clear, maybe not clearly defined, but like defined enough that it is serving that goal. And if it's not, then it may be not only neutral, but working against you. Is that kind of what you're speaking to?
Yes, that's what I'm trying to say. Yeah. And the other thing is that we know a lot about the safety of these psychedelic drugs when taking in an acute high dose in one setting, right? So taking it once, but we have no idea what happens when you take these drugs for a long time, and people are taking it for years at a time. And we have actually very limited toxicology data on what can actually happen when you take these drugs for so long. So some of the things that have been described as changes to the heart, for example. I haven't seen any clear evidence in one way or another, but we know from other drugs that are binding to these receptors that can be a potential issue. And another thing that I have on my mind that I don't have any proof of, but if you have increased flexibility in your brain and you have increased synaptic plasticity, and these neurons are more proliferal and they can move more, it wouldn't be a good combination to combine that with a brain tumor, for example, or glioblastoma. So if you are getting that to grow more, that would be a devastating event as well.
I mean, I assume that's like in sort of isolation from any of the other potential benefits that psychedelics may have on neural tissue, like neural inflammation and these kind of things.
Yes.
Maybe it could be helpful, maybe it could be harmful.
We have no idea.
Right. I mean, one thing that just came to mind, and probably I'm not the first person to think that, is like, well, if it's ultimately placebo and there is neuroplasticity and it's placebo, then theoretically, if we found a substance or a class of substances where we could effectively actualize placebo in our lives, well, that might actually be quite a helpful drug after all.
Well, we have plenty of drugs that induces neuroplasticity, or plenty of interventions. You can just go run for a run. I mean, or do a new start to learn something. Read a book, or I mean, there's plenty of things that induces neuroplasticity. So it's not specifically to psychedelic drugs.
Yeah. So you had said you wanted to come back to a comment that I made around the research being convoluted by a kind of like lack of clarity as to exactly what drug is being microdosed. Because look, I get it. LSD, psilocybin, DMT, I think in some respect like mescaline, DOI, there's like all these ones, and there's like 5-HT2A receptor, but these are still very different drugs, and that's not even considering things where like ibogaine being microdosed, which is a totally
and then people
different
microdose
drug.
everything from cannabis to MDMA to but let's stick to the psychedelics, because
the classical psychedelics.
Yeah, what we do know is that LSD is a really promiscuous drug. It binds to a lot of things in the brain, and psilocybin may be also binding to a kind of a few of the serotonin receptors, but then we have something like mescaline or DOI that only binds to a very few. So the differences in pharmacology between these drugs are just so big that it would be really strange to assume that they're going to do the same thing in the brain. Like, what we're actually working on at the moment is also to trying to see what are the different effects of high doses of these drugs, and are there different measurements in the brain that are visible or measurable when you take mescaline versus LSD versus psilocybin, and we do see that they produce different effects in the brain. So yeah, they're trying to put all these things together and calling them psychedelics, and psychedelic microdosing is really also polluting the scientific literature in a way. We need to split it up into the different drugs in order to start to understand what's actually going on.
Mm-hmm. Yeah, totally agree. I mean, as an observer, an outside observer of the science and the sort of like non-science culture, it reminds me of, now maybe I just misread it, but there were a number of times that I have read research suggesting that there's like no real difference between psilocybin and LSD when you look at it, like all the data from a subjective, and they're basically the same. And I'm like, I just cannot imagine any person who has had both say these are the same drug, these are the same experience, because they're just so radically different. And I think there needs to be a lot more specificity, and I think there's a lot of value in finding that specificity and identifying the specificity, because, you know, like a healthy forest, you don't just say trees and that determines a healthy forest, right? Like there's a lot going on, a lot of different trees, a lot of different supportive plants that you didn't even think were playing a role over here, which makes space for
anybody
something
who
else.
read Shulgin's book will know that there's differences between these drugs, right?
Oh,
so we need more research on that way. And I think if we go 10 years or 20 years ahead, there will be, and if we are using these drugs in the clinic at that time, there will be a drug for depression, and there will be another drug for anxiety, and there will be another drug for those disorders where we may see a potential at the moment. I think we will start to branch out and see maybe LSD is better for anxiety and psilocybin is better for depression, or the other way around. But I think that's probably a pretty good assumption. And is there a case for mescaline at all, or is it just going to not be relevant? I don't know.
Yeah, it's funny because you said 10 and 20 years we'll have a specific drug for this. My brain went like very futuristic, and I was like, in 10 to 20 years with AI and everything else, for all we know, we're going to have do androids dream of electric sheep, Philip K. Dick style of like the exact experience you want, just like perfectly dial that in. Like, I want a 739 because that's going to give me exactly this, and none of this, and this, which is different from a 732 because that's this. And like,
science doesn't work that fast.
I went super nerdy about it in my mind. Maybe I admit I read probably more science fiction than science, but
but I think so that it is actually where the field is going with regards to DMT, right? Because the DMT experience is, I mean, you can't ingest it like you can with psilocybin and LSD. You have to have it injected, and the way it's going right now is that you can inject a little bit and then a little bit more and a little bit more, and then you can actually get to the level where you want people to get, and then you can have the effects that you're hoping to get. So maybe your future will be true with regards to DMT.
I mean, even with regards to DMT, we have the work from people like Chris Timmerman and the extended state DMT, and it's not just like, you know, getting to the level, but you're also like getting to, you know, a desired or predetermined time in, no longer relying and no longer sort of like at the whim of your body's sort of like default metabolism of the thing in and out. Injected, smoked, or otherwise, because of course outside of the research center, most people aren't injecting DMT. But yes,
no, I wouldn't recommend that.
No, I would imagine I'd be so surprised if you were like, I recommend people intravenously inject their DMT. Probably not. Just get a vaporizer. But anyway, so that aside, I'm getting maybe a bit too silly here at the end. There is I think there's an incredible future available to psychedelic medicine with specificity, and I think with the appropriate caution around how we let sort of social biases manipulate what kind of what direction we take these drugs. But I didn't intend on asking you this, but I'll ask it anyways because it's kind of coming up and you're in the field. Recently there was this, FDA denial with respect to MDMA, and everybody had a different take on it, or like lots of different takes on it. Do you feel like that represents, do you have any concerns for the future of psychedelic research and their approval in clinical settings based on an event like that? Or do you feel like we're pretty good, like we're pretty full steam ahead at this point?
I think it may be actually be a good thing for the psychedelic drugs because they're going to learn a lot from that event and probably do it in a different way, the approval process. So maybe the approval process will turn out much easier for psychedelic drugs in the end because they will know what mistakes not to do from the previous.
Well, this has been a wonderful conversation. Got a couple of finalizing questions. The first one is, Mikael, what are you working on now? I mean, maybe it's relevant to the microdosing research. And like, what are you excited about in the research for yourself right now?
Yeah, right now we are working on, I alluded to it a little bit, to the different effects between different psychedelic drugs. And we have actually been looking at comparing a pharmahuasca, so a scientific way of producing ayahuasca with just having two drugs and giving them at the same time, comparing that to psilocybin, to 2CB instead of mescaline, and then LSD, and trying to see if there's different effects of these drugs at high doses.
Effects at the neural level, you mean, or subjective level? So you're working with rats?
Neural level in rats again.
Okay,
and we're using imaging to see what happens in their brain over time. And that's coming to an end. So I'm really looking forward to hopefully presenting that to the public soon. And then we're going to look into microdosing a lot more with animal models, and maybe animal models of some kind of diseases like stress or stress-induced anxiety or stress-induced compulsive behaviors, and see if we can see the same effects that we saw in normal rats, and if we can see a better effect of that in animals with some kind of disease. And other people are working on that as well, and it seems to be a good way to go.
Well, excellent. I am personally quite excited to see your research as it comes out. And for people who are listening, is there a particular way, like, are you active on social media that people could follow the research coming out, or would you recommend some other pathway for them to stay up to date with the research you and your team are putting out?
I'm trying to stay off social media as much as possible. I'm trying to get away with all the compulsive actions to do something on my phone. So I'm actually only active on LinkedIn. That's the only social media I'm on. But anybody can go and follow me there and find it. Other than that, I would much rather speak on podcasts and go and present the data in talks and presentations.
Excellent. Well, thank you so much for being excited and willing to come here on the show today. I really appreciated it. And that's all. Thank you so much.
Yeah, you're welcome.
Okay. And cut. Okay. That was this episode of Adventures Through the Mind. I hope you found some value in it. If you are interested in Mikael Palner's work, Dr. Palner's work, you can head to jameswjesso.com in the show notes to this episode. I'm going to link to the various studies that he's put out, in particular the one that we talked about here today. I'll also put a link to his LinkedIn profile if you'd like to connect with him there, as he did say he's not much on the social media. And if you'd like to stay in contact with me, I have a Blue Sky account. It's jameswjesso.bsky.social. I don't actually remember how Blue Sky works. I'm pretty new to it. So I'll put a link of that into the description here. I'm also on Instagram, where I share clips from these channels, Telegram, and I also have an email newsletter. So all of these are follow ways. You don't have to necessarily rely on the algorithm to the newsletter one. So keep that in mind. And I don't normally mention this near the end of the episodes, but I'm feeling like maybe it's time for me to start saying things. But if you ever find yourself interested in preparing for a psychedelic experience or wanting to have some extra support in making sense of it, in particular if it was difficult or challenging or disorienting, I am happy to sit on a call and offer some coaching on integration. It's something that I've put a lot of time and energy, money, and training into getting rather well versed at from my personal experiences and in helping others. And if you are interested in going into that kind of experience of integration support with me, I am available, and I will leave a link to doing that in the description to this episode. And so maybe that's another way we connect, maybe not. Either way, this has been episode 194 of Adventures Through the Mind, and you've been very generous in an era of distractibility and the deluge of content to have given me, an hour and a half-ish plus of your time. So thank you very much for that. And until the next episode, take care and stay curious.